people may join us throughout the presentation, but we are recording it. And if you're comfortable, it'd be great to share the PowerPoint with everybody for their learning. And if anyone has a group joining this, maybe let us know how many people you've got joining the session as well. That's always helpful for us when it comes to, as I said earlier, our future planning. And there is also just some housekeeping. There is a survey that I've put in the chat. If you just click on that at the end of the session and provide us with some feedback, that'd be really useful as well. And I'd also just like to quickly acknowledge the First Peoples of Australia. We are on, I'm on Dja Dja Wurrung country, and we respect elders past, present and emergent, and we recognise that sovereignty was never ceded, and this is and always will be Aboriginal land. And I'm really delighted to welcome Brad, who is doing the presentation on palliative care and end-of-life care, and hand over to you, Brad. Thanks so much.
Thank you, Abby. Thank you, everyone, for joining. The presentation we're presenting today, or I'm presenting today, is palliative care and end-of-life care. And this presentation was done in conjunction with Tamara and Kerry, who are clinical nurse consultants here at Residential in Reach in Mildura. And the slide has been adapted from our colleague, Annette Emonson at St Ranger Community Health Service. She is a clinical nurse consultant specialist for palliative care. Our objectives for this session will cover the role of the palliative care team. We'll discuss end-of-life care and how to identify residents approaching end-of-life care, symptom management and medications, when to start subcutaneous medications and syringe driver, and supporting dignity, comfort and end-of-life wishes for our patients and their family. So I guess it's probably good to start off with having a definition of palliative care. And the World Health Organization defines palliative care as the approach that improves the quality of life of patients and their families who are facing problems associated with life-threatening illness. And this can be done through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, including physical, psychosocial and spiritual. As part of palliative care, you have a palliative care team, and each service will have a palliative care team that they can refer to. And the palliative care team can be consulted for providing assessment and developing plans of care with patients with the following problems, anything ranging from pain to goals of care, psychosocial and spiritual care, a whole range of areas that we can or that the palliative care can assist with. Of course, this is not an exhaustive list. That can help with a lot more. Defining end of life can be considered, by definition-wise, end of life care is the last few days or weeks of a life in which a patient with a life-limiting illness is rapidly approaching death. This is when you'll find that the needs of the patients and their carers will be the highest at this time. And it's also this phase of palliative care recognised as one in which increased services and support are essential to ensure quality coordinated care from the healthcare team being delivered. And generally speaking, people who are dying need care in 4 areas: physical comfort, mental and emotional needs, spiritual issues and tasks. So how do we identify that a resident is approaching end of life? Again, this list is not exhaustive, but experiencing day-to-day irreversible deterioration, requiring more frequent interventions. But generally by this stage, your GP or the client's GP has all the evidence I need to suggest that this is a life-limiting illness and there's nothing more that can be done. Intervening with medical care will only provide, how can I put it, a loss of their ability to continue on with life, whether it be mobility or what have you. So they can become semi-conscious, lapses of consciousness, increased loss of ability to swallow, decreased swallow reflex. Food and fluids and generally oral meds, they will be refusing. Decreased urine output, an acute event, and changes in breathing patterns are generally things that we see, especially in patients with cancer. A quick onset of severe pain is something that we see a lot of. On the bottom here, I think is really important. Early delivery of palliative care reduces unnecessary hospital admissions and the use of health services. And with residential inreach, that's one of our main objectives, is to reduce unnecessary hospital admissions to the health service. On the right-hand side there, you can see this, the phases and layers of palliative care. And you can see, I think this demonstrates that palliative care encompasses end-of-life care and terminal care. I think that's a good diagram to demonstrate. Carrying on to common medications for pain. There are some other slides I've got coming up which are more specific, but generally you'll find that patients will have medications for pain, which is one of the main symptoms. And morphine is one of the most common ones. There is some contraindications there for each drug, as you can see. What's interesting to note is the half-life of morphine is 2 to 4 hours, and the standard PRN subcutaneous dose is 2.5 to 5 milligrams. Of course, that varies depending on the person. Someone like myself might need 7.5 milligrams, whereas someone that's smaller and shorter might only need 1.25. It's really depending on the patient and the clinical scenario that you have. Fentanyl is another drug that we, a pain relief medication that we use if they've got allergies to morphine or hydromorphine. But fentanyl only has a half-life of 30 to 60 minutes. So if you give a 50 microgram dose, in roughly 60 minutes, that 50 microgram dose is going to be reduced to 25 microgram dose just by the metabolism of the body. Hydromorphines are another good one there, but it's really important to note morphine and hydromorphine are not the same drug, in that the hydromorphine is really, really concentrated. And as you can see, the dose there is 0.5 to 1 milligram compared to the morphine 2.5 to 5 milligram. Anxiety and restlessness is another symptom we commonly see with palliative care and end of life. And medications we use for this is midazolam, 2.5 milligrams subcut. That can be hourly in PRN, especially at the end phase. People may need a lot more than the early stage. Haloperidol, 0.5 to 1 milligram subcut, is also useful. And as you'll see on the next slide, this haloperidol can also be used for nausea and vomiting. Clonazepam drops. There was a phase there where oral Ordine was the flavour of the month. And I think more evidence and research is coming out that clonazepam drops actually have more better effect for patients. And the most important thing with clonazepam drops is that it's sublingual, so it can just be put inside the mouth on the buccal mucosa, which is really good, especially if your patients have trouble swallowing. Just makes it easier to give. Although it does note here, the patient still needs to be alert enough to tolerate. As I just discussed, the common medications for nausea and vomiting, you can see the haloperidol there, but the Maxilon 10 milligrams is mostly the mainstay. Ondansetron is also another medication, antiemetic that can be used for nausea and vomiting. Secretions are a big problem with end-of-life care and palliative care patients, not necessarily for the patient, but for the family. It can be quite distressing hearing that, that rattle and that moist cough. Medications that we use include glycopyrrolate and hyoscine. And as I noted on the bottom there, it's not always effective if commenced too late. And it's quite beneficial to educate the family and loved ones that secretions are not painful for the patient, but they just sound distressing for them. And do not suction at this, may create more secretions. It's very tempting to put a Yanker sucker in and clean the secretions out that way, but it's really important not to put it at the back of the throat or that to cause any more. A really useful website that I found for anticipatory medications. Anticipatory medications are medications that we use if we believe the patient is imminently moving into end-of-life care. And this can be quite useful, especially if the weekend's coming up, no GPs on or less medical cover. And if the patient's heading in that trajectory, then we can initiate anticipatory medications that can be charted by the GP, and then we can initiate that use over the weekend if needed, or after hours on a night shift. And this is from the Safer Victoria website, which has got some really, really good resources for palliative care. As you can see, they're pretty much all the drugs that are spoken about. Part of caring for somebody with end-of-life and palliative care is having a care plan that helps keep that continuity of communication between shifts and staff for caring for a patient. This is another example of a care plan from Safer Care Victoria. And this I find is useful because it actually comes up the top with the symptom, and then you can follow the algorithm that's best for that patient in regards to helping with their pain. The next slide will show you other symptoms that you may have: nausea and vomiting, dyspnea, and respiratory tract secretion. So it's actually quite a good website. These are just example care plans. A common question that we're asked in residential hemorrhage is, when do we start subcutaneous medications? Certainly with palliative care in the early stages, the patient normally is still quite with it, can eat and drink, and we're just relieving the symptoms earlier on. And so quite often they'll be on oral medications, but when to start subcutaneous medications is important to know. So when they start to become unable to tolerate oral medications, they might be decreased GCS, they might be drowsy, poor or unsafe swallow, then we can start subcutaneous medications. Also, if they've got poor absorption, so you can give the medications, but they're just not absorbing it into their stomach for whatever clinical reason that may be. We normally start off with PRN, which is subcutaneous injection, or a butterfly, which we can give the subcutaneous medication through. But the other question we're asked is, when can we start a syringe driver? And what is best, a PRN medication or syringe driver? So when the oral route is no longer available or not optimal, then you need to consider other routes for that. So one of the rules, not exactly a hard rule, there is varying opinion, and it's not set in concrete, but we generally wait for when 4 or more PRNs have been administered on a 24-hour period. Some will do it for 3. Again, as I said, it's flexible, but as a general rule, when 4 or more PRNs. Of course, once the syringe driver starts, if the patient's still in pain and got symptoms, then we still need to give PRNs on top of that. Then when the palliative care or residential hemorrhage team review the use of the PRNs in the 24 hours, we can increase the base rate of the syringe pump. So end of life, indications of physical pain that you may see in your patient include moaning, groaning, restlessness, sighing, crying, fearful expression, appetite changes, rapid breathing. They're just some examples of when you might cues that your patients will give if they can't verbally tell you that they're in pain. And we need to, of course, address that pain by either giving a PRN or increasing the base rate of the syringe driver. Emotional pain is another sort of pain that a lot of people don't talk about, but for a client or a patient, the inner feelings of distress, discomfort, or unhappiness, coming to terms with the terminal phase of what they're going through. And we see this as very common for people who are seriously ill, and it can be related to concerns about health, family, finances, the future, and grief as it's approaching. They will grieve as well as their family. So it's very important that we address or acknowledge this emotional pain. Now, this is an interesting one. Spiritual pain is not necessarily related to religion. I know that's probably the first thought that comes to mind when you think about spiritual pain, but it can be in the search of meaning of peace, forgiveness, or love. And this could possibly be a time of growth and reconnecting with loved ones, even unexpected joy. But we also need to acknowledge when there may be unexpected disappointment as well, and which we support the patient through that. There could be conflict within a family, and this phase has brought them all together, and they've been able to make peace together. So yeah, it can present in many different ways. So with end of life, indications that we see of terminal agitation. So we'll generally see fidgeting, twitching, angry outbursts if they're still conscious, but otherwise there'll be aggression, unsettled behaviour, irritability, hallucinations and paranoia, and a cognitive decline, confusion. We would manage that in a clinical scenario as needed in conjunction with the GP, but that might be something medications can help. Haloperidol will certainly help with that, or maybe other medications like quetiapine or olanzapine. And end-of-life secretions, we commonly refer to this as the death rattle. And I'm sure most people would have heard of the death rattle and heard it themselves in the clinical practice. It's generally caused by upper airway secretions, not the lower respiratory issues. So it's not fluid overload, it's not pneumonia, it's secretions in the upper airway, which becomes more louder, I guess. It's generally not uncomfortable or distressing for the patient, but it is distressing for the family members or carers, especially if they've never experienced it or heard that before. And so we always ensure we have appropriate explanation to the family members regarding these secretions. And moving on to injection sites. So when we look at subcut cannulas, that's generally through a butterfly cannula. So suitable sites here, anterior aspect of the upper arms or anterior abdominal wall, and the anterior aspect of the thigh. And you can use the scapula if the patient's distressed and agitated and they're pulling at things. If it's in the abdomen and they're pulling it out, you can use the scapula. And the anterior chest wall as well, if they've got subcutaneous tissue there. If they're quite thin or emaciated, that may not be an option. It goes to say that sites that are not suitable include skin folds and breast tissue, particularly skin folds, because you're going to cause pressure sores with the butterfly there if it's been enclosed and pressure is placed on it. Limbs that are have edema, well then your absorption is going to be reduced. So it's not an optimal site. Abdominal wall, if the ascites are present, same as the edema, you're not going to get optimal absorption because it's full of fluid. Bony prominences, the absorption will be reduced. You've got to remember with subcutaneous that the medication is absorbed to the subcutaneous tissue. And if you have very little subcutaneous tissue, then that's not going to be absorbed appropriately. Previously irradiated skin, it's going to be like burnt skin really. It's going to be red, quite sore and painful, so you don't want to be injecting in those sites. Near a joint, they become quite uncomfortable, like in the cubital fossa in your arm, becomes quite uncomfortable and risk of displacement. And any infected, broken or bruised skin you need to keep away from. The little picture here on the screen shows you some good sites. Of course, the first part on the buttock, I probably wouldn't do the buttock if it's a butterfly, because you're going to create a pressure area sore. But if it's a PRN, just a once-off, or a you haven't got a butterfly in, and that can be used as a site to inject. Moving on to family support. the patient's our main concern, but the family is also just as equally as important. So supporting them with the palliative care needs is an important aspect of our routine care. And all members of the healthcare team have a role in providing this support. One thing to note is that family should be interpreted in the broadest manner. Family is whoever the patient says is family. We don't need to ask for identification or a birth pool map showing who is legitimately our brother or sister. It's whoever the patient says is their family. Now, quite often the family members are quite willing to take on the role of principal carer, but they can find this quite stressful as well. And so support from us to that family member is really vital in supporting them and making sure they don't become overwhelmed. And family meetings as well are really helpful to provide information and discuss the concerns so everybody's on the same page. And the family can also have input into the care plan as well. And this is beneficial for both sides, from healthcare professionals and the family. Now, just some useful websites. Some of these are provided by our colleague Annette. The Caring at Home project and the Safer Care Victoria ones are the ones that I found. I'll just show you the next one. The Palliative app. This is available through the Safer Care website, Caring at Home project, sorry. And this is really useful for healthcare professionals in that you can see the screen here. You can press the green button and it'll come up with symptoms, so pain or nausea, and then it will tell you what medication is ideal to use or optimal to use. Or you can click on the medicine button and it'll tell you all the drugs, and you click it and it'll tell you what it can be used for. And then there's a dosage opioid calculator as well, which is useful for clinicians that need to convert from, say, oral MS Contin to subcutaneous morph. And this allows you to do that. So this is a really, really useful app, which I've even downloaded onto my phone. I find it quite good. Another resource for health professionals that are supporting families is the Caring at Home app as well. And it's designed to make it easy for people to get quality end-of-life care if they choose to die at home. And it has resources for the family, healthcare professionals, etc., as well as some training videos. If you are educating the family member how to give PRN medication if they choose to do that. Another one that the Caring at Home project has as well is the Caring at Home for Indigenous population. And we find that particularly useful up in the Mildura area. And this is an app that's designed specifically for the Indigenous population. And it has a whole lot of downloadable and tailored best practice culturally safe resources for healthcare professionals as well. Is there any questions? Yeah, I'll just a little slide here. This is Annette Amundsen. She's one of the clinical nurse consultants with Palliative Care Western Asia Community Health Service, and she's been absolute invaluable resource for us in this region. Each region that you come from, or each area, will have their specific support from a palliative care nurse consultant and services. And that is my presentation, Abby.
Lovely. Thanks so much, Brad. That was really informative. And there were so many add-on resources that you've linked your presentation to. Are you comfortable if we share this with the group?
Absolutely, yeah.
Session? No, that'd be great. Only because you've referenced a few different sites and apps and bits and pieces that could be really helpful to people.
I found a lot of especially the Caring at Home project, and that was absolutely fantastic resource for everybody to use, and the Safer Victoria app as well has really, really good resources.
Yeah, that's brilliant. And I imagine they would keep those resources up to date as well,
Yes.
based on the nature. That's always the, I suppose, conundrum with digital platforms. You don't want them to become redundant with new reforms and what have you. So
That's right. There's actually some parts of those, I think the Safer Victoria website, where it'll actually say, please note this page is being reviewed and will be updated as soon as possible.
yeah,
You know,
I
that does
have
tell you.
noticed that. Yeah, Safer Care Victoria are really good with that. And they date everything, so it's really clear to everybody.
Yep.
So thanks so very much for
No
that
problems.
very informative presentation. Are there any questions at all? Because this is a great opportunity to share any questions or problem solve as a group. That's the idea of a community of practice. No? What would be helpful before we get on to some residential and reach general business? It'd be great just to take a couple of minutes to click on the link that's in the chat and complete the survey. We'd be most grateful for that. And then we provide, obviously, feedback to the group based on the survey completion. I'm just going to, I think, Kathy, you on the call?
I am. I was just looking. I can't actually see the link in the chat. Is it in the chat or is it in the invite, the Outlook invite?
It was actually put in the chat, but I think it's because I put it in
could be just
earlier.
me, but I can't see a link.
No, I think I went in earlier, and I think it's obviously not saved to the new. I've just copied it and put it in there. There we go. Can you see it now?
Yes.
Great. I thought I was being a bit clever, getting in early and popping it in, and then it saved it to obviously another meeting, which is a shame, but that's okay. Was there anything else that you wanted to discuss, Kat? We'll take a couple of minutes to get the survey completed.
No, look, I think it's just a great opportunity for people to ask questions, particularly with regard to palliative care. So, you know, if people are identifying particular challenges or things that they're needing, you know, support for, a great opportunity to talk to Brad, and he might be able to offer some support and advice. Otherwise, I suppose it's really about just opening up the floor if anybody's got any other I suppose things that they wanted to flag or discuss in a forum where we're all working in similar spaces that we could probably talk through or problem solve. But yeah, we would absolutely really appreciate everyone, while we're just taking the few minutes for people to have a think, to also fill out the survey, just so we know people's feedback on how the session went today, and whether there's also any ideas for any new topics that perhaps people might like covered in the future.
Yeah, excellent. I'll go in and see if they're coming through, if the feedback is coming through. And 2 responses so far. So thank you. 3 responses. Thank you so much for those who have started to fill out that evaluation. So Brad, some nice instant feedback. It's always good to get feedback when you've facilitated a session. So far, everybody was really thrilled and found the session particularly useful. They've learned some new skills about different medication that can be used at end of care. the different methods of pain control, anxiety, and various apps that can support the knowledge, and great new resources suggested with the links.
Oh, that's good. I'm glad people are
It's nice when
enjoyed
you
it.
get it in real time, isn't it? Get that
Yeah,
feedback.
yeah,
Yeah,
for sure.
well done.
A lot of those resources I use myself, so they're actually tried and trusted, and yeah.
That's great. Thank you so much to those of you who are sharing the flyer when we develop it. Kath's got another comment.
Yeah, I just thought it might be worth just mentioning that our next community of practice is in 2 months' time, and the topic's going to be around continence. So worth just having a think about, particularly sharing that information with your teams. We will send a flyer out as we have this time and in previous times with information about when the session is and what will be covered as part of the continence topic. But certainly if you've got any ideas or thoughts about particular areas that you would like covered, please feel free to pop a comment in the chat or email Abby. That would be fantastic. But I just thought it was a good opportunity to promote the next community of practice with the topic being continence, and Dalkaya Health are going to be facilitating the session.
Yeah, fantastic. Thank you so much, Kath. And also we'll do a follow-up with the resources that Brad has kindly put together, as well as a bit of a summary of the evaluation. And we'll also promote that next PD session and save the date so you can, rally the troops and get everyone engaged to attend the session. It's really pleasing to see, and Kath, this is nice for you to hear, the format, 100% people are happy with the new community practice format. They are sharing the flyer, and yeah, they found this session particularly useful and helpful. So that was good. Excellent. Thanks for your feedback, everybody.
And a big thank you to Brad for the session today.
Yeah, well done.
No problems. Thank you.
All right, everyone's got a little bit of time back in their calendars today, so that's probably grateful for most of you. And you can have access to that survey. I'll share it also if you haven't had time or you've had to dash off. So please complete that, and we'll see you next time. And you'll hear from us in the next couple of days.